Are we good to start?
We are. Well, let's do introductions first.
Yeah.
I appreciate y'all from Concordia.
We are.
Yes.
Really good. Okay. Thanks for coming.
Thank you.
Pleasure to be here.
There are a couple of folks who are online, which will join Matthew and I, who are here in the room. My name is Kevin Harrington. I lead program management for Alcon. If any of you wear contact lenses, you may know our product. Anyway, I live in Atlanta, Georgia. I'm fortunate to participate in the program for several years. I have one wife, I have two children. I intend to keep those ratios constant. I was coming here. So anyway.
So yeah, my name is Matt, and I am not a corporate compliance officer or lawyer by trade. I publish a newsletter for corporate compliance officers. It's called Radical Compliance, but my audience would be a lot of people like Kevin and other compliance officers. I've been writing about it for probably about 20 years. So I like to think I have a sense of what the issues are, and I'm glad to be here.
Awesome. We're glad to be here too.
Excellent. Can our online judges introduce themselves?
Hi, just sound check. Can you hear me?
Yes.
Wonderful. I am Cy Bryant. So I am in corporate compliance, and I've been this way for the last 15 or so years. So I'm joining from Richmond, Virginia today, and I'm very interested to hear the topic and be involved in the discussion. So thank you for having me.
Okay.
Well, Cy, I used to live in Virginia Beach.
Do you want to introduce yourself?
I didn't hear.
Okay. Okay, well, we'll get started. I have some instructions to read. On this time. Just give me a moment. And I recall it was for 30 minutes. Good. Okay. So let me just kind of read through the instructions. I'm sure you all have probably heard them before. Can you all hear me well enough online?
Yes.
Excellent. Okay, really good. So this part of the competition, you're taking on a fictional business identity, assigning a fictional business identity to the four of us, the judges. Please make sure everyone knows who you are and who they are before you begin. You'll have 25 minutes with a 5-minute cushion. Describe the legal, financial, and ethical dimensions of the problem and recommend a solution that passes muster on all three accounts. During this time, teams will be uninterrupted. When you're finished, judges will ask you questions for 20 minutes. During the question and answer period, both you and judges stay in character. After the Q&A, the judges will give you feedback outside the role playing. So we'll say, I'll mention, we've completed the role exercise, okay? And we'll go from there. Some important things to keep in mind. The ethical aspects of your analysis are the most important part. However, these should be described in a simple, practical, common sense fashion. Using technical, philosophical terminology for basing your argument on religious or theological grounds will be considered a serious weakness. Similarly, any member of the team realizing his or her part, or reading his or her part rather, will also be considered a major mistake, although you may use notes. During the presentation, every member of the team must have some sort of speaking role, okay? If I will probably take notes during your discussion. I'm not drawing pictures. I'm just trying to help myself remember things, okay? Really good. Let's see. Loving y'all. Go ahead when you're ready.
Everybody ready?
Yeah.
Well, good morning. We are Vilnani Sachemar Company. My name is Benedict, Matangi, Miriam, and Leanne. We're here today welcoming you, the board members of the American Medical Association, American Hospital Association, and the National Medical Association, in order to talk to you about a huge problem, systemic racism in the healthcare system. And we brought you here today to ask you to come together on this front in order to tackle the challenges, because we feel you'll be stronger together than alone. And it's really important that we look at how we can foster a new relationship between Black Americans and the healthcare system in order to build trust moving forward. Because if we don't, the reality is that we are going to be facing and having this conversation still in 25 years from now, and Black patient outcomes are only getting worse. And we would like to talk to you about how we can do that through a national program we call CARE. The reality is Black patients are unhealthier than their counterparts across the board statistically. And worse than that, the risk of mortality is significantly worse. Just look at breast cancer. 900% more risk of death for HIV. The odds are stacked against Black Americans when it comes to this. And I ask you, how can they possibly trust the healthcare system with outcomes like that? Furthermore, how can they have better outcomes if they don't trust, if we don't help them trust the healthcare system? The reality is that the system is broken. So how do we get here? Long history that you're very well aware of. 1910, the Flexner Report, 5 out of 7 medical schools, Black medical schools were closed. The most perhaps infamous biomedical research study in US history, the Tuskegee syphilis study in 1932, in which 600 men participated in an experiment and were not actually properly informed of the nature of the diagnosis of syphilis, nor 10 years later, when it was widely understood that penicillin was a treatment for this, were they given the proper treatment that they needed and deserved. In 1951, Henrietta Lacks had DNA from her cancer cells taken without her knowledge or consent, and those cancer cells, that DNA is still used in studies today. And it took until 60 years ago for the Jim Crow laws to finally be abolished. So what are the impacts of that? Experience in the healthcare system of just all the things they face on a day-to-day basis, stereotyping, implicit bias, lack of cultural knowledge, and all of this builds further distrust in the system. And these have major consequences, medical consequences, as well as socioeconomic consequences. This leads to bad, unhealthy behaviors, missed appointments, lack of trust in doctors, and this just drives worse and worse outcomes moving forward. So we want to ask, what can you do together in order to foster trust in the healthcare system for Black Americans better than you can do alone? Because you face some huge challenges: lack of representation with Black doctors as physicians across the board, implicit bias, lack of cultural understanding, and of course, the long history of discrimination. Our CARE program is founded on 4 pillars: community, access, representation, and education. We want to ask through community that you implement and help spearhead a program to implement health hubs across the nation in order to expand trust through the community in locations, public locations that are familiar to the neighborhood. Equity outreach specialists in hospitals across the nation in order to help patient and employee support. Developing pathway programs so that Black doctors, children who want to become Black doctors can see that from start to finish, and we can improve representation over time. And then absolutely revamping education, not only at the medical school level, but also in continuing education for professional healthcare workers by improving cultural understanding and through implicit association testing. All of this will help us build trust in healthcare. Why we chose your 3 organizations is because, first and foremost, you all have a tremendous amount of power when it comes to speaking and dealing with the government. And you all have a mission that is directed towards equitable care and driving better patient outcomes. The American Medical Association absolutely is focused on equity. The American Hospital Association wants to improve art and medicine, and as well as better public health. And of course, the National Medical Association really wants to promote health and wellness and eliminate health disparities across the board. So let's look at this through the lens of a patient journey. Joyce is 27 and she finds herself pregnant on December 1st. On January 10th, she feels that she can't trust the doctor. She feels judged because she has diabetes that she can't keep under control. March 4th, due to financial strain, she stops taking her prenatal vitamins. And when it comes to Tyson's birth, he's born at 31 weeks premature. And the reality is his life will be harder than full-term babies. Miscommunication leads to a lack of doctor interventions, and Tyson is 65% more likely to work in low-level occupations. Henry, 48, he's diagnosed with hypertension and diabetes. In 2015, he smokes to cope with the stress. 2016, he also feels judged because he can't keep his diabetes under control or his hypertension. 2018 rolls around and his health is spiraling out of control because the medication for his hypertension does not work. And this is a common challenge that Black men face when it comes to hypertension medication. And in 2024, he eventually has a heart attack, does not receive the care that he needs and deserves, and dies. And the reality is his cardiovascular diseases account for nearly 40% of the disparity in the life expectancy for men like Henry. And I'm going to ask my colleague Matangi to discuss the ethical issues.
Thank you, Ben. Now let's look at the ethical standards that may have come into play for Henry and Joyce and for the Black Americans as a whole. I ask you, are you living up to your promises to Henry and Joyce? American Medical Association, have you provided equitable care for all? National Medical Association, have you eliminated health disparities? American Hospital Association, have you achieved betterment of health for all Americans? How are Black Americans being adversely impacted? Black Americans pay 20% of their household income for healthcare. Black Americans are more likely to be dismissed from residence. Black Americans face a decreased life expectancy of 6 years. And 31% of Black Americans face a delay in healthcare simply due to cost. Black Americans have faced years and decades of systemic racism and oppression. Due to that, there are still many barriers still in place today. This is why providing an equality care is not enough. We need to have catered resources towards the Black Americans to be able to remove these barriers and to be able to provide the care they deserve and to be able to provide health equity. Now let's take a look at the laws that are present and how they act towards providing care. The Civil Rights Law in 1964 has put an end to segregation and has allowed for equal care to all. In 1986, the Emergency and Medical Treatment and Active Labor Act has put it mandatory for all doctors to treat all patients in emergency despite their affordability. Medicaid Act and Affordable Care Act both has helped lower income households to be able to afford healthcare insurance. Overall, there are many health laws that are present that can be separated into two buckets: public health law and healthcare law. Public health law, which ensures the welfare of all citizens, and healthcare law, which is focused between patient and physician relationship. But the question is, are these laws alone enough to protect Henry and Joyce? And the answer is simply no. Legislation alone is not sufficient to reduce racial disparities. There are many aspects that go beyond what a law could determine. Two key elements being systemic barriers and human barriers. Structural inequalities, the complexity of the healthcare system as a whole, implicit bias, and resistance to change. You, AMA, NMA, and AHA must resolve systemic and human barriers. Now let's take a look at what this represents in terms of finance and numbers. Healthcare inequity cost is projected to reach $1 trillion by 2040. You must reverse this trend. If this alone is not enough, I don't know what will be. Economic burden faced by ethnic health disparities is on the rise and is reported at $451 billion in 2018. Black American paid the largest burden of this, representing a 70%, $351 billion. This is why we're here to present to you through the lens of Black Americans to reduce health disparity, and reach health equity. Beyond what the numbers could tell, you cannot put a price to life. Black Americans face many misdiagnoses, diminished quality of life, adverse side effects due to medication, and simply distress and trauma in the healthcare system. Everyone deserves care. Now, I will pass it to my colleague Miriam to speak to you about care.
So what is care all about? In the community pillar, we want to establish health hubs to reach the community, bridge the gap through healthcare, and really assess the needs of the local population. In the access pillar, we want to have an advocate for Black health into every hospital that deserves this population. So we want to implement equity outreach specialists. In the education pillar, we want to promote diversity in the medical literature to have more different skin tones represented throughout the medical journey. And in the representation pillar, we want to revamp the pathway program so that small kids in local communities that don't have role models can aspire one day to be doctors. For this, you'll need a coalition. You'll need to come together, AMA, AHA, and NMA, to spearhead a government funding campaign to have the funds to help those health disparities. We foresee that the NMA will lead the community pillar because they're the one who knows more the needs of this community. And then the AHA will be both in the access and the education pillar. And then the AMA will lead the representation and the education department. So in a community, we want a place-based approach. So use places that are already trusted by the Black community. So you can have public schools, you can have churches, you can have pharmacy, places that are already used by the community and that they feel safe and heard there. And you want to implement health hubs. So the NMA will spearhead this project and will collaborate with community leaders to really understand the needs of this community and then implement nurse practitioners so that they can tailor to those needs and improve the healthcare system. The nurse will have special training to really understand the issues, the connectivity and the needs of the community. And with that will lead to more trust, improved health literacy, and better outcomes. And what are these health hubs gonna offer? Ongoing and everyday care. So if you're Henry and you just got your diabetes diagnosis, you can follow up with your nurse practitioner to make sure you're well treated. If you don't understand diabetes, you can have more information. If you cannot afford your medication, she can relay you to the pharmacy who has a program to have more affordable medication. So she will be the resource to help you get the care that you need. You can have blood pressure medication management there. You can have vaccination, let's say for COVID, we could have saved many lives. And she will also be able to help you navigate the insurance system, as we know, it's very complex. So present in public spaces will improve care and in the end, reduce costs. So we foresee that we will need about 750 health hubs with about 3,000 nurse practitioners to really be present for this community and help them have better health outcomes. And it won't be cheap. It will cost almost $1 billion just for this health hub, but we really think that is going to improve the health outcomes of the Black community in the long run. Now for the access pillar, we want to implement equity outreach specialists. We want a voice for the Black population within the hospital. So this job description will be, he will be in charge of accompanying patient consultation. If they don't trust their doctors, they will be the relay to make sure that the information is passed from the patient to the doctors and back to the patient. He will also be in charge of having an open door policy. So every healthcare professionals, whether it's a doctor, a pharmacist, a nurse, they can come and ask their question to better understand the cultural differences and how to better treat their patient. They will also be able to spearhead the diversity training that we'll implement in the education pillar. And finally, they will have to stay aligned with the best practices across the country to make sure that every Black people is heard and have the best care possible. So we'll increase patient advocacy and with that, reduce biases. So we foresee that the AMA will be in charge of providing the guideline for this role. And then the AHA, who will be in the hospital, will spearhead the implementation of this position and also make sure that there's a connection with the health hub. So let's say Henry has his diagnosis at the hospital, but then it's the nurse practitioner in his community that he trusts that will do the continuing care. And then the NMA will be the voice of the program to make sure that the Black community is aware that we're thinking about them and that we're caring for them. We'll build more trust, improve the Black patient experience in the hospital, and have better health outcomes. And with this pillar, we'll need an additional 600 million to achieve our goal. And then Leanne will talk to you about representation.
All right, thank you. All right, now that we've talked about how we can improve communities, have better access, let's talk about how we can increase representation of Black medical practitioners and how we can improve diversity education throughout the medical education pathway. So current pathway programs are in place. However, they suffer a number of barriers that we've identified as leaky pipelines. Some of these barriers include a lack of support, limited personal resources, social family conflicts, and inadequate guidance and monitoring. In addition to this, we know that 21% of these pathway programs have adequate website information to guide people to their resources. Only 10% target elementary schools, and as a result, only 13% of these pathway programs measure their outcomes. We know that racial concordance, meaning the ability for a patient to see a health practitioner that shares the same racial or ethnic background, actually does improve health outcomes. So what will it take to make a successful pathway program? The first pillar is to start in as early as possible. So to start in elementary schools and follow students throughout their educational pathway so that if they are underperforming, we can intervene early and provide them the support they need, and that this support needs to be sustained throughout their education. Other resources that need to be provided as part of a successful pathway program include not only funding, but mentorship opportunities, training, tutoring, and time management tools. Family involvement is very critical to the success of programs such as these. As part of our care strategy, every medical school should have a pathway program to help develop the future of diversity in healthcare practitioners. So we know currently that Black medical students have a much higher attrition rate than their Caucasian counterparts. In fact, Black medical students are dropping out at almost twice the rate as their Caucasian counterparts. And this is due to a number of barriers that they face during their education, including discrimination. They are being held to higher standards, and many of them pay a minority tax. The solution to address some of these issues include having DEI training, leadership support, and providing additional resources across their medical education journey. Support is required through the medical education pathway, not simply to get there, but also throughout as young Black students become doctors. What's the goal? The goal is to reach representation equal to the Black population over the next 15 years. So currently only 5% of medical student cohorts are Black students. The goal is through these pathway programs to increase this representation to 13%, which is the percentage of the population that represents Black Americans in the general population. So the cost of better representation is estimated at $51 million annually to help revamp these pathway programs and improve retention among Black medical students. In our last pillar, we're going to talk about how we can increase diversity education throughout the system. So the Harvard Implicit Project has shown that across 3.6 million Americans surveyed, there is a very clear favoritism when associating white people with good outcomes and Black people with compared to Black people. Bias is important because it has a direct impact on how people are treated and receive care. And so we believe that in terms of education, 3 things are required. First, that the promotion of diversity in medical education needs to be improved. At this time, only 5% of medical textbooks actually show diverse skin tone representations, which makes it a lot harder for medical practitioners to actually identify issues with Black people if they don't have any point of reference. We need to rethink the implicit association test and how we could potentially curtail this to the healthcare system and leverage this as a measurement, as a tool to measure our DEI efforts, and finally, to track our DEI efforts across the board. So how can we further enact this strategy? First, by having online resources that showcase diversity. Second, to partner with publishers of medical textbooks to increase the amount of diversity shown in throughout the educational pathway. To increase cultural competency training, and to track the diversity amongst the leadership and the students of medical schools and medical practitioners. And finally, to track the data in terms of what our efforts are and how are we improving or limiting bias throughout these initiatives. So we believe that the cost of better education ends up being approximately $10 million per year. So now that we've gone through our care strategy, let's look at some of the financials associated. We believe that combined our care strategy results in a cost of approximately $2.4 billion per year. Now we know that's a large number to put up, but when we consider that the cost of health inequities in the Black population alone is costing $310 billion to the American population, $2.4 billion in comparison is not even 1% of that overall cost. The goal is to reduce disparities by 10% over the next 5 years. And we believe that our return on investment over the next 5 years will be approximately 7 times. Now to conclude, we need you, the NMA, the AHA, and the AMA to work together to present this care project to the government, because we know that it can have significant impact on the lives of Henry, Joyce, Tyson, and millions of other Americans just like them. Thank you.
Very good. I actually want to begin with. What makes the issue you're discussing in ethical issues specifically?
Sure. Well, first and foremost, when people don't receive the care that they need and deserve, and they face systemic issues and structural inequalities, it violates just a simple principle of fairness. And when they can't live their lives with dignity and the health outcomes that all humans deserve, then that presents a very much strong undermining to those principles.
I guess my next question would be, are there examples, they may be within a state or another country, that perhaps contrast with the current situation that may be a model or opportunity to aspire to?
Yes, actually, the current situation is that there's many opportunities that are being presented across either communities or across cities to improve those outcomes, but there's very localized. They're not across the whole nation. So there's a lot of good projects, but have very limited reach. So what we're trying to present today is a national approach so that every Black American can hope to a better life.
Okay. You mentioned the relationship between Medicaid, the Medicaid Act of 1965, and more recently the Affordable Care Act. Have you all had a chance to look at what was the current state of care and some of the metrics that you shared during in either of those, and maybe how they've changed or improved, if at all, over time since? Or perhaps maybe they've not improved or only improved in a negligible way.
Yeah, sure.
Well, the Medicaid was a very good initiative, but unfortunately, in the states where the Black population is the most present, it has a very limited reach. Since every state has its own discretion in how they open it up to their community, the state that needed the most don't have the better results with that. So since it's not, it was, don't get me wrong, a very good initiative to help the Black communities or at most the poorer communities that need it, but it was not enough to really improve those health outcomes as much as we wanted.
Okay.
To bridge back the gap.
Very good. So if I follow, those initiatives were on one hand needed and had at least limited success, but they don't go far enough as opposed to having failed or whatever reason been stopped.
Exactly.
Okay.
Exactly, it was a step in the right direction.
Very good. Okay. And again, this is an issue at the federal or the national level versus at the state level. Okay.
So I am still just a little bit confused about exactly what you are asking us, the hospital and medical associations, to do. Are you asking us specifically to put up any investment money, or are you merely asking us to advocate for the policy proposals, which are not unreasonable, and the ethical issues are certainly there. But for example, the AMA and the NMA, if they are more about coming up with policy recommendations and marketing or awareness outreach, I get that. I wasn't quite clear on exactly what the American Hospital Association should be doing to put the health hubs in place. And then at the very end, I saw you had a strip across the bottom on your last slide saying support the government's implementation of this program. So are you asking us to do it? What exactly are you asking us to do? Or are you asking us to cheer on the federal government that it should do it? And the it makes sense, but what are we doing?
Yeah, I can go with that one. So what we're asking is for the three organizations to come together. First, I'll just address first the funding portion. We would like the organizations to come together to lobby the government for the necessary funding to support this initiative. But then we believe that the combination of your three organizations is required to implement the actions for our different pillars, which with each organization taking a different lead role on individual pillars, but being involved in each pillar. So like if the NMA is taking the lead on one of the pillars, we still need the AHA and the AMA to collaborate with them, but they would be taking the lead on potentially a different pillar. So in terms of resources, it's not so much funding resource from these organizations, but more the knowledge, the people. So I guess maybe from that perspective, there's a bit of funding, but the people and the knowledge is more what we need the three organizations to come together as a coalition and drive the overall initiative.
And I guess the only other question I have is, I do think that the poor health outcomes for Black Americans, clear, compelling. I also though wonder, would the solution maybe have a rising tide lifting multiple boats, that there are other racial groups here or poverty groups that also, they don't have great health outcomes either, but getting physicians simply to listen to people who might have different experiences and complaints and frankly, different skin tone, getting them to listen better could have other positive ramifications as well. I don't know if you have any research or thoughts about that.
I can speak to that. I mean, it's a pretty simple answer on that one. As we showed earlier, it's first and foremost, the worst outcomes by a significant portion are for the Black population. And so at a bigger scale, we see this as a potential pilot program too, at a large scale, where the reality is if this works, which it will, to help the Black population, it's going to help many other underserved populations as well when it comes to whether it comes to race or disability.
Very good. From our online judges, any questions at this point?
Yeah, I have a lot of questions. Let's get started with something.
One of the,
Something simpler is around, have you thought about which legislative body, the Senate or Congress, who would sponsor this bill? Because in reality, it has to get into a bill, and it feels like our organizations would be witnesses in any testimony to the Senate, for example. But what area, because we would need a congressman or senator to start with, which area, jurisdiction, geography should we target as a first pass at this?
I think it just simply, in terms of the geography, 56% of the Black population live in the southern states. So if we want to get down, we want to focus on those states first and foremost. And as well, if funding is difficult to attain from the government, then there is some funding, though at a much smaller scale, with especially with the combination of the AHA and the MAA, that you could implement some pilot programs to test in those southern states.
Okay, so and absolutely talking about the cost is another, I'm sure as you can see, is a big issue. Cost and timing feels too broad or too aggressive to implement a new program. So do you have examples of similar programs that have been successful that we're emulating or learning from before we get started with any of this?
Yeah, especially there's a couple of anchor strategies that were implemented both in New York City as well as Chicago, one with the Rush Institute, that were extremely effective, not only in improving health outcomes, but wealth outcomes for the community as well.
And also for the pathway programs, we base our solution based on a winning story from University of Louisville, who changed his program with all the criteria that we named and had a significant improvement in the diversity of their 5 to 10 years medical school, medical students.
And to also add on, similar to the equity outreach specialist in South Bronx, they implemented social workers in hospital, especially dedicated to reduce health disparities. And they found that for every dollar they invested, they were gaining $2 back because they had lower emergency admission, lower mixed diagnosis, and lower healthcare costs for the hospital itself.
Okay, I got a few more for you, okay? So just the hospital network and the school network as well. Again, because these are extreme costs, and I'm sure as you just heard the case around, not using race as any kind of judgment for entering into school at all. It feels like this is proposing that we would go back to leveraging race as a key identifier for being accepted into a part of a college, including med school. So how would we address that?
Actually, we don't plan on having a favor towards Black students coming into medical school. We want to help them from elementary school so that they have the right caliber to enter on their own the medical school that they want. So by offering tutoring and mentoring throughout their journey from elementary school to high school through their undergrad, we foresee that there's going to be enough so that they have the caliber to be judged as fairly as the others and enter by themselves into the school.
And so that being said, that's what I expect you to say, right? It feels larger than just the medical community needed to step up to be able to help and change the health outcomes here. And you gave the perfect example, I think, in New York, where it was a financial acumen as well, because it's access to medicine, not just knowledge of medicine, that makes a difference. So what other groups or organizations or nonprofits should we be engaging to help move this forward?
May I also ask a question tied in with Dr. Bryant? Can you hear me?
Yes.
Okay. First of all, I think you also need to deal with the unions. Secondly, you're dealing with the whole civil rights movement. Thirdly, rural schools are closing, medical schools, where many African Americans had been attending. So you have a universal problem that needs to start with the top and start with the bottom and meet in the middle. I come out of New York City and we went through all of this. You're not going to change it step by step you have a problem across the country, and particularly unions. They also segregate. So how can you handle something that's so universal?
So just to summarize, because we have questions from both of you. So the last question was really how can we handle this issue when it's a universal issue, and ultimately there's the challenge of the fact that you have to deal with multiple states, multiple unions, multiple actors who all have different regulations, different policies, different states, et cetera. And then your previous question, Doctor, was the fact that what organizations at the ground level, other than these three large organizations, want to get involved in order to affect that change. Am I correct? Just to reflect back to you.
Yes, and I would also go further in terms of hospitals that are run by religious institutions, whether it's Mormons or Catholicism or the Jewish hospital in New York. See what they are doing, and if you can make a difference in the process. But just,
Absolutely.
well, it's not going to work. It's a civil rights movement forever. And I've been involved in all of this.
Yeah, so I mean, do you want to?
I can speak to the last question.
Yeah, you go for it.
So that's exactly why we're proposing our CARE Act, and we're proposing to all three of you board members to have an impact on a national level. So we don't have any more things happening at a state level, and to be able to oversee all the hospitals, all the medical school, and be able to implement this in a way that's universal to all of America.
And just I'll start macro and come down micro to the first question, which so at macro again to tag on to what Matangi said with the National Medical Association. I mean, just what they accomplished with bringing in Affordable Care Act. There's an ability there to affect change, but also the relationships across all of your associations, whether it's the hospital association has relationships with all the hospitals as well as various other clinics, et cetera. The American Medical Association has relationships with not only the licensing bodies, but also the accreditation programs for the universities. Just to give you a quick scan of that so that we can go down when we're working back to the ground level. In answer to your first question, it's about partnering with universities, anchor institutions, i.e. being institutions that are old enough or strong enough in the community that they're not likely going anywhere. So that not only includes the health systems themselves and the educational systems, but that is the churches, that is the elementary schools, those are the libraries and the community centers, as well as partnering with community leaders so that the proper community health assessments can be conducted and place-based community needs assessments can be conducted in order to implement change in each specific location that is actually based on what that community needs. And those conversations and community quote unquote listening tours can be conducted so that they're really creating their own change from inside without. But the top-down approach is that conversation needs to be also had at the federal level, and ideally there needs to be funding from the government to support this.
For our other judge, you had one more question?
No, I was going to say that's a very true statement.
To the other judge.
I'm sorry, compare Lebanon in the Bronx to Montefiore in the Bronx. Totally different. In terms of Montefiore is first class and Lebanon suffers. This is the American history, unfortunately.
For our other judge online, you had another question?
Is it frozen?
No, it can be frozen.
Yeah, it might be okay.
Yeah.
And
any other questions?
also seeing
I don't.
hospice organizations.
This is the last question I have. If you all had a chance to read either possibly the charter or the mission statement of the AMA or the HMA, anything specific in those documents or foundational principles that are specific to this problem or may be critical to how the organization you're addressing today should take responsibility as you've suggested or recommended?
Yeah, choose you on it. Okay, they're long documents. And they are addressing the entire population when it
Yeah.
comes down to it, right? And of course, you're very well aware of the issues here. When it comes to specifically this challenge, I think what it really comes down to is your mission statements again, which is equitable care for all. And when you're focused on equitable care, not just equal care, then it's about taking into account what the individuals you are serving have to face in order to get the care that they need and deserve. And that's where it's failing.
Very good. Okay. We're gonna come out of this, the simulation. So we can have a sort of a candid discussion at this point, okay? Matt, thoughts?
Out of curiosity, how did you all wind up tackling this topic? Is it sign?
No, we chose it.
Okay.
This is-
Because I don't know if I should have brought this up while we're in character or not, but like, this is a big problem and you're proposing big solutions. I somewhat think it's just too much for everybody to chew. But a lot of your individual solutions, it actually, they make more palatable sense. That said, I thought the presentation was generally very good. The slides were, some of them were a bit confusing and unclear. I had one that there was one slide that it's the timeline slide that was way too busy. And it was also kind of monochromatic. Like, it's hard for people to follow along. And there was another one where it was the pathways slide. That's unfortunately is all my notes. But you had a bunch of statistics that were alarming, but you framed them in the wrong way. Like, only 26% did this. Well, that actually means something like 75% don't do this. That might be a more compelling way to prove the point, is to frame things negatively. Some of the numbers, while I don't doubt that they are true, I would have liked to know where they come from. If it had been a real board meeting where you said something like it's $1 trillion in cost because of healthcare inequities, I don't doubt that it's large. If I were a congressman reviewing this or a real board director, I'd want to know, where did you get the trillion? Like I said in a previous case, I think a lot of what you were saying is pointing in the right direction. I'm just not sure, are we on stable ground? Are we here? Are we there? But the other way to think of it would be, what if we did nothing? Well, if we did nothing, everything here that is alarming would continue to suck. So it can't continue. I like to say that always remember that doing nothing is also a choice. And a lot of boards would actually prefer to do nothing because they don't want to take tough problems. And you could point out, doing nothing is also a choice, and it usually comes out to be the bad one over the long term. But overall, it's quite good. It's a lot. It's a big deal. It's a big thing.
Do you want to share why we chose them? I don't know.
Sure, go ahead.
Starting my story?
Yeah.
Yeah, okay, so how I initially came across is, me personally, my dad had open heart surgery recently, and prior to the open heart surgery, every single of his appointments, like his diabetes, his cholesterol, everything was like, his blood test was normal, no signs. He was like taking down and putting down the tempo by himself, changing card, like purposely fit man.
Yeah.
And then one day when he was walking, he had like a little chest burn. In my head, I thought it's acid reflux, but he has no history of acid reflux. So I'm like, let me go check it out. Turns out that he has 6 of his arteries are blocked. And I was like, what? This is not aligning. Like, there's no, long story short, no one was understanding why this was happening. None of the doctors were able to provide me or like my family with an explanation, up until I came across an Indian practitioner doctor, and he then gave me the explanation is because South Asians are more prone to having a certain type of fat that is higher, and that's not something that's tested as a standard blood test. So that happens very rarely. And also South Asians have smaller arteries that is not known, so they're more prone to having heart attacks. So that's how this like the surprise came about to us, and that's how it got me thinking. I'm like, initially we started also talking about clinical trials and like the lack of diversity in clinical trials.
Yep.
But we felt that was kind of a limited scope, and we just kind of went on from there.
Okay.
Yeah.
How about for our online judges, feedback?
Yeah, I think I definitely echo that same comment. This was a massive topic. So thank you for sharing your own family's history around this. I think one of the key things that I would have loved to know from the beginning is you wanted us to advocate for you in Congress. I think that came about literally at the very end. And I had a totally different mindset going in. And I did do my research, read the executive summary. I really came in and went to the presentation thinking you wanted us to give you $360 billion. And I was just trying to think about why you even think we had that much money. So I think starting with the outcome is always a good way to get started. And just like my colleague said in the room, knowing the risk strategies. So you can do risk assessment, risk avoidance, risk transfer, or you can just mitigate. Mitigate is the last thing you do. So it's almost like, what else could we do besides this? It would be wonderful to offer alternatives to going all out. This seems like an all out way to address it holistically. I think as you heard from our other colleague, right, this is a massive issue that people will not want to do. And that's the ethical component of it is, and I think I would have wanted you to spend more time on the ethical thing of why don't we want to see everyone have the same health care? And why don't we trust? And I think one of the other angles to consider is like, just because I'm Black does not mean I know all the Black things. So not necessarily introducing more Black people to medical school will address Black people's issues or concerns. It's having the right framework and culture and history that elevates you to a different understanding. And I'm not sure if you're aware, but if you grow up in different environments, you're not talking to the same Black person, right? So that Black person, as you mentioned, grew up in the Bronx is different than a Black person that grew up in Brooklyn. They literally experience different healthcare systems. And what we have to try to figure out through this example, I would have loved to figure out is, just like you gave those three examples of, a pregnant mother and her baby and the person that had diabetes, replay that in a different environment where the right system was in place to give them a better outcome of life. And we have to realize nothing we can do can eliminate every health risk, but we just want them to have a better chance of living a full life. So I would have loved for you to come back to those three people in a different scenario if this works. So sell the positive, not just the negative.
Yeah,
Thank you.
that's great.
Thank you.
That's all doing that.
But the unions, have you left them out of your consideration? The unions.
Sorry, can you repeat the question?
What about the unions? Are they part of your consideration? The unions.
Like for the actual, like the nurse practitioner unions, et cetera?
I'm sorry, I didn't hear. I
Just the
asked,
healthcare professional unions?
yes, don't you have to get involved with the unions in terms of what's happening?
I would say so.
Have you,
Valid point.
Valid point, yeah.
Who are the constituencies that would have to be on your side to get this done?
Yeah.
The unions would have to be on your side, or this is not getting done.
exactly. So that's an area that also should be looked at.
Yeah.
But,
Any other feedback?
but this is a whole country issue.
Very good. A couple of things. First of all, I thought you guys did a really strong job. It is a big topic, obviously, but a powerful and compelling topic indeed. Some things I really liked. The presentation format you're in is not easy, okay? I have the occasion to present frequently, far more so than I would prefer at work. And the one you're in is probably the most challenging. When your presentation is behind you, you're standing as opposed to sitting with your audience. And you don't have the opportunity to read from a script or notes. Well done. That is hard. Probably the hardest format you'll encounter. Okay. The other thing is sharing a presentation stage with a limited amount of time is also hard. It requires disciplined planning. You've got to stay in your lanes. And well done there as well. I appreciate, I'm guessing you guys have rehearsed this more than a few times. Okay, really, really good. I also like, there's several things I like about what you had to say. I like your examples about the Tyson baby and Henry, who's a 48-year-old male. I like to mention the Tuskegee example, which is remarkable thing that happened, in the last 100 years. Thanks for citing Medicaid and the Affordable Care Act. Because clearly there have been initiatives, or at least with best of intentions perhaps, with some desire to rectify or address, not perhaps this is a specific exclusive problem, but this problem is part of bigger problems. Couple of thoughts. You never know who the audience is in this scenario. Typically you do. Typically you know the people you're presenting to. And that's another challenging element. I work in healthcare. Okay, and I work in med device product development. So one of the things we consider is what are the places, where are the countries we want to market products? Why? We go to those countries because that's where the money is. You make a lot more money in med device reimbursement in the UK and Western Europe and Japan than you do in the US. Where does the farm industry make all its money? In the US. Very, very disparate. My point is, in making arguments, first start with, as I think some of the other judges mentioned, focus on your audience, who we are, okay? Tell us about who we are and why this issue is not only compelling, but exclusively compelling to us. Mission statements, past examples, things that we work on. Everybody has limited funding, everybody has limited resources. Why should this be at the top? Think about that in talking to the audience. Think about examples either, I asked about the states or about other countries. Think about other examples of things, for example, I'll just say AMA, that they've done, that they've been successful or effective at, and how this aligns with whatever their goals or mission, or past successes. So I think you guys did a great job with your examples and distinguishing why this is such a big problem and opportunity. Also consider where we've come from and other examples why these organizations should be on board and why this is a call to arms to the audience you're addressing. Okay, really good. It's the problem with big topics in this type of, in our format, it's tough to shorten them down. So if you go to the shorter sessions, really think about what you want to focus on. Don't try to cover it. Don't boil the ocean. Be very selective in what you bring forward in terms of what's most compelling. Okay. Great job presenting. Great job in terms of choosing the parts of the topic you did. I really like some of the questions from our judges online. Thank you for participating. Thank you, Matt. It's been a pleasure as well. Any feedback or questions from us? Or for us, rather. Oh, good.
Yeah, I
Okay.
will say my feedback is the feedback is great. Yeah,
Excellent.
it's really useful to have, even just in listening to all of you and the questions you posted just shows there's an opportunity to see where the ability to synthesize information and what the important questions to ask are. And that's something that can be carried into our careers moving forward and into our lives. So thank you very much.
Absolutely. Yeah. Know your audience, be specific, speak to them about the things that will be compelling to them, which requires knowing who those folks are and what they're about. It's a challenging environment because I work with the people I present to. I know what they're about. I also know what the questions are going to ask me. You don't have that privilege in this structure. So really, really good job. Have you worked together before? Or is this the first occasion?
Yeah, we've all worked together.
Yeah.
Excellent.
Yeah.
Really good.
Every-
Okay, I appreciate learn some things.
Everything said is true. However, you don't even know if these organizations want to work together. So I suggest that you start from the base of nursing schools and medical schools. Tell them what the problem is as you see it and have lived it. How can they make a difference? Go to the high schools, go to the graduate schools, and get to talk to students. There are Black societies at school. See what you can do at the grassroots level, because at the top, everyone has their own discriminatory views.
For the
I'm
Our other
sorry.
online judge, any feedback?
I'm finished.
Oh, maybe
think it's
it's
frozen
frozen
again.
again.
Okay, Matt, any other thoughts?
No.
Okay, thank you.
All good. Okay, pleasure. Thanks.
Thanks
very
very
much.